Hello, my name is Donna Edwards, and today we'll be discussing child abuse and neglect in substance abuse treatment. Child abuse and neglect defines a description of screening and assessment tools for identifying individuals with child abuse and neglect issues, presents comprehensive plans for treating adult survivors, discuss ways to break the intergenerational cycle of child abuse, and explains legal responsibilities and resources. There are physical, emotional, and sexual abuse and neglect during childhood which can increase a person's risk of developing substance abuse disorders. Children of substance abusing parents, in turn, are more likely to be abused or neglected, resulting in an intergenerational cycle. Here are some of the issues. Compared with other substance users, clients with childhood abuse histories have more severe substance abuse disorders, start using substances at a younger age, use substances for reasons that differ from those of other clients, have a higher attempted suicide rate, show more post-traumatic stress disorder, have personality or relationship problems that make them hesitant to accept help, and they are also more vulnerable to relapse. Here are some definitions. The Child Abuse Prevention and Treatment Act defines child abuse and neglect as any recent act or failure to act that results in imminent risk or serious harm, death, serious physical or emotional harm, sexual abuse or exploitation to a child below the age of 18, or accepting sexual abuse below the age specified by child protection law of the state, by a parent or caretaker, including any employee of a residential facility or any staff person providing out-of-care home, who is responsible for the child's welfare. Types of child maltreatment are neglect, failure to provide basic physical, educational, medical, or emotional needs. Physical abuse, injury inflicted by deliberate actions. Sexual abuse, engaging a child in sexual activities that the child cannot comprehend, consent to, or be prepared for developmentally. It includes all forms of sexual contact, non-touching abuse, and commercial exploitation, incest in the imposition of sexual acts or acts with sexual overtones on a child by persons who have authority through ongoing emotional bonding with that child. Some states define abuse as an act of perpetrated by a caregiver and assault as an act committed by a non-caregiver. However, it is commonly held that any use of force constitutes of sexual assault. Emotional or physiological abuse is an act of commission or omission that causes serious behavioral, cognitive, emotional, or mental disorders. It is the most difficult form of abuse to identify. The counselor should consider the meaning of trauma or abuse to the client, the effect on the client, and not just legal definitions. Childhood trauma can increase the intensity of treatment services required, lengthen the time needed for treatment, and increase the number of sessions needed. When screening and assessing adults for childhood abuse or neglect, childhood abuse and neglect often alter a child's perception of the world, leading to feelings of betrayal, an inability to trust, low self-esteem, and great shame. The following reactions, symptoms, and disorders may result: self-mutilation, depression, thoughts of death, suicide ideation, feeling hopelessness, dissociative response, aggressive behavior or acting out, including with early sexual activity or sexualized behavior with physical, abusing, or harming animals, poor relationships with one or both parents, attachment disorder, difficulty trusting others, excessive passivity, passive aggressive behavior, blackout time frames, no memory of periods during childhood, excessive nightmares, extreme fear of the dark, or a request for locks on doors. Post-traumatic stress disorder, eating disorder, borderline personality disorder, excessive anger and shame, anxiety, high tolerance for inappropriate behavior, arousal, hyperactivity, age regression, derealization, depersonalization, emotional and sensory numbing. Screening and assessment should be done in a safe, non-threatening environment early in the comprehensive assessment process. At different times during treatment, several factors may accurate screening and challenge underreporting or overreporting of trauma histories and symptoms, repressed memories, coexisting psychiatric disorders. Elicits more information about traumatic experiences, especially after trust has been established in the therapeutic relationship. No one should screen for childhood trauma without proper training and supervision. Counselors should learn to understand the effects of childhood maltreatment in the adults, on the adults' feelings and behaviors. Identify individuals with symptoms of abuse or neglect. Clinicians are more likely to ask female clients about past childhood maltreatment, but many male clients also were neglected and abused, including sexually as children. Here is a look at some of the standardized screening instruments: the ASI, the CTQ, and the PARQ. The Parent-Child Relationship Inventory, the Screen for Post-Traumatic Stress Symptoms, and the Traumatic Symptom Checklist. Direct questions to use in childhood abuse or neglect screening. Questions about traumatic events. When you were a child, were there any significant traumatic events in your family while you were growing up? For example, deaths, hospitalizations, or incarcerations of a parent or sibling, divorces, or chronic diseases. Were you treated harshly? Did you ever experience physical, sexual, or emotional abuse? Do you experience inappropriate physical or sexual contact with an adult or person at least 5 years older than you? Was there violence in your household, such as battering of siblings, a parent, or his or her partner? Do you feel that your parents neglect you? Do you have adequate food, clothing, shelter, or protection? Did your parents frequently use alcohol or drugs? Did you ever use alcohol or drugs with them? Questions about circumstances suggestive of traumatic events. Have you or has anyone in your family ever been involved with Children's Protective Services? Did you ever live away from your parents? Were you or your siblings ever in foster care? Do you ever feel unsafe or in danger? Have you ever felt that abuse or neglect was your fault and that you deserved it? Assessment. A positive screen indicates that more information and a thorough assessment are needed. Also consider the client's readiness to discuss the issue, the input of members of the treatment team, the families involved. Family of origin characteristics to consider during an assessment include a history of parental substance abuse and/or violence, CPS involvement, the placement of children in foster care, the use of severe discipline during childhood, traumatic family separations and losses. Ask for information about the type of abuse with physical, sexual, or psychological abuse with neglect, with exploitation, multiple forms of abuse. Whether the perpetrator was a parent, other relative, stranger, teacher, or caregiver. The frequency and duration of abuse. Example, ages at onset and cessation. The context of trauma, including the use of force or fear, the family's knowledge of and response to the abuse, any mental health counseling or other treatments as a child, how and when the abuse was disclosed, and its social and legal consequences. Treatment programs should have written protocols that describe the who, when, and where of screening and assessments, the information required, confidentiality and reporting regulations, each treatment team member's role, the screening instruments to use, how to present, discuss, document, and interpret findings, how to incorporate findings into treatment plans, and standardized tests should be used as guidelines to conduct screening and assessment. Assessment tools. Here are some mental health assessments. The Beck Depression Inventory, the Brief Symptom Inventory, Profile of Mood States, Symptom Checklist 90 Revised, Mini International Neuropsychiatric Interview, the Psychiatric Research Interview for Substance and Mental Health Disorders. Schedule for Affective Disorders and Schizophrenia, Structured Clinical Interview for DSM-5 Axis 1 disorders. The trauma-oriented tools include the Assessing Environments, Childhood Maltreatment Questionnaire, Trauma Assessment for Adults. The Traumatic Event Scale, Dissociative Experience Scale, Modified PTSD Symptoms Scale, Self-Report Version, the PIN Inventory for Post-Traumatic Stress Disorder, the Post-Traumatic Stress Disorder Diagnostic Scale, Trauma Symptom Inventory. The Child Maltreatment Interview Schedule, Childhood Trauma Interview, Trauma Assessment for Adults, Evaluation of Lifetime Stressors, the National Women's Study Event History, Clinician Administrated Post-Traumatic Stress Disorder Scale. Comprehensive treatment. Acknowledging past child abuse helps clients break through secrecy and shame resulting from abuse. Talking to a sympathetic listener can be an important first step in the healing process. Counselors should show their unconditional regard, non-judgmental attitude, and sincerity. Be sensitive to the client's cultural background. Be a sympathetic listener. Acknowledge and validate the client's experience by recognizing the issues and refocusing the treatment to address the issue. Provide a link to mental health services if the client needs additional treatment. Adhere closely to accept standards of practice, ethics, and legal requirements. Delicately discuss the past abuse in the presence of the family members who were involved. Disclose abuse with tact and sensitivity. Explain the treatment itself and when and how abuse issues will be addressed. Clients' subjective experience of and feelings about the abuse can shape their physiological response, more than the actual circumstances of it. It is normal for clients to be uncertain about the abuse or not remember at all that it all happened. The counselor should support the client's recall, reinforce that the feelings about the trauma are the most significant aspect of the experience. Consider the client's coping strategies and their effectiveness. Substance abusers generally go through 3 stages when dealing with their childhood maltreatment issues, which may take years to complete. They are Stage 1, 0 to 30 days. Substance abuse treatment begins. In-depth attention to childhood trauma issues is not appropriate. Stage 2, 31 days to 2 years. The client may be able to address childhood issues. Stage 3, 2+ years. The client is able to deal with a broad range of issues. Never force clients to confront abuse issues. This may create an abusive situation and re-traumatize the client. Whether to address childhood abuse is the client's choice and depends on the client's symptoms and ability to stay sober. Some individuals with childhood abuse issues may not do well in group settings, so group therapy may not be appropriate. Gender-specific groups are generally more beneficial. For most clients, therapeutic work, in addition to substance abuse treatment, is required for full resolution of issues. Tell clients their history of child maltreatment may have contributed to some of their errors in thinking and decision-making. They may have medicated themselves with substances to avoid dealing with their feelings. They are not alone, and resources are available to help. They can learn better ways to cope and live a happier life. Involving the family in treatment. If a client and the treatment team agree to include family therapy and substance abuse treatment, it should be conducted by a licensed mental health professional with specific training in childhood abuse and neglect. Whether family therapy is appropriate depends on the family's knowledge and acknowledgement of the abuse, the client's feelings and preferences, the current relationship among family members. Counselors should be cautious about discussing child abuse issues with family members. This may not be therapeutic or essential for every client. Mental health treatment services. Counselors should consider their limitations when working with clients who were severely abused. Although it is in the best to treat the substance abuse or mental health issues in the same venue, this is not always possible. When a client's mental health problems are beyond the counselor's treatment ability, a referral must be made to an appropriate provider. Clients raised in abusive households learned how to function in an unhealthy environment and did not learn healthy interpersonal behavior skills. Counselors should model these behaviors and expect their clients to do well. Be warm and respectful. Be sensitive to cultural concerns. Recognize potential language differences. No excuse Not excuse the parent's abusive or neglectful behaviors because of cultural differences. The violence and cruelty clients experienced upsets many counselors and results in intense reactions. Counselors should be aware of the effect a client's story has on them, their own countertransference reactions, any judgmental or insensitive attitude, and the need to seek supervision. Counselors must be aware of the following: transference, feelings and issues that the client projects onto the counselor during therapy; countertransference, a counselor's reaction and response to a client's issues. The counselor loses objectivity and becomes overwhelmed, angry, or barefoot about the client's experience. Secondary traumatization, symptoms of trauma that are brought about by repeated confrontations or disclosures of victimization and exploitation. Burnout, when work pressure erodes a counselor's well-being and interferes with his or her personal life. Counselors should not work in isolation, seek to treat individuals with a variety of problems, keep a manageable caseload, receive support from their agency, recognize when they are unable to work with a specific client and refer that client to another provider. An agency can support counselors by providing a sense of mission, providing ongoing clinical supervision, supporting their efforts to keep their caseload manageable. Treatment frame. Develop a treatment frame, the set of conditions necessary to support a professional relationship with the client. Its parameters might include specifying regular appointment times in advance, enforcing set starting and ending times for each session, declining to give out a home phone number or address to clients, canceling sessions if a client arrives under the influence of alcohol or psychoactive drugs, not having client contact outside of the therapy session, not having sexual contact or interactions with a client that could reasonably be interpreted as sexual, terminating counseling if violence is threatened, establishing and enforcing a clear policy regarding payment. Building trust. Because adults who were abused or neglected by their parents have experienced betrayal in their most significant relationships, they often cannot trust others. The counselor should remain consistent and available, help allay clients' fears and abandonment and rejection, show unconditional positive regard, maintain a non-judgmental attitude. Breaking the intergenerational cycle. Children whose parents abuse substances are more likely to be abused or neglected than other children to grow up and abuse substances themselves and to abuse their own children. Adults who are victims of childhood maltreatment often have difficulty parenting because of their inability to trust, choose emotionally healthy partners, manage stress, nurture themselves or others. Family-centered interventions are the most successful at breaking the cycle of substance abuse, child neglect, and child maltreatment. Just as substance abusing parents often deny their drug use, they may deny neglecting or abusing their children. Who abuses and why? Characteristics shared by parents who abuse their children include considering child rearing difficult and unenjoyable, using excessive controlling disciplinary techniques, not encouraging autonomy in their children while maintaining high standards of achievement, promoting an isolated lifestyle for themselves and their children, expecting their children to take on a role of a caretaker. Other characteristics of abusive parents include poverty, substance dependence, mental illness, feelings of inadequacy, of self-reproach, often related to early negative experiences, depression, difficulty articulating their needs or feelings, anxiety, seriously arrested development, a sense of incompleteness resulting from a failure to internalize separate identity, manifested by clinging to their children, having other abusive of unfulfilling relationships, an inability to tolerate being alone, fear of taking responsibility and making decisions, severe difficulty with verbal communication, difficulty in seeking or obtaining pleasure, extreme narcissism, gross immaturity, independence, and impaired ability to empathize with a child's needs. Some children avoid becoming part of the cycle of abuse. These children tend to exhibit resilience factors such as insight, sensing that life in the troubled family is not normal, independence, separating from the troubled family, other relationships, fulfilling needs not met by the troubled family through others, intuitive, attempting to overcome negative feelings, creativity, transforming pain into something worthwhile, humor, making tragedies into something funny, morality, understanding common mores of good and bad as they exist both inside and outside the family. Role of the counselor. By working closely with a substance abuser, the counselor can break the abuse cycle. The treatment provider should become familiar with the client's family life and any parenting behaviors that might indicate possible child abuse. Parents who abuse substances differ in experiences and parenting skills. Questions to ask clients to gain insight into their home life include: what groups give you support? Do you have any special friends? Do you belong to a community or faith-based organization? What type of social activities do you enjoy? How often do you participate in them? Have you been involved in the criminal justice system? When? Have you ever been on probation? Have you been involved with other social service agencies? With CPS agencies? Why? Who else lives in your home? Who else spends time there? What is your routine each day? On weekends? What do you do with your children each day? On holidays? Are your children receiving ongoing medical care? What is their health status? Does anyone care for your children besides you? What is his or her role and attitude towards the children? If the counselor can observe how the client relates to his or her children, the counselor should consider these questions. How does the client react to the children's behavior? How does the parent respond to their emotional needs? Do the children make eye contact with him or her? How does he or she respond to the children's crying? How does the parent praise and discipline the children? And are the parents' expectations age appropriate? In addition to the above questions, counselors treating clients who do not have custody of their children should learn about the CPS agency's plan, requirements, and schedule for family reunification, the client's history for custody challenges and outcomes, behavioral clues that suggest possible child abuse or neglect include name calling, belittling, or negative labeling of children, telling stories that suggest children are living in unsafe conditions, example given, being left alone, blaming children or directing misplaced anger at them that may mask guilt or poor parenting, having inappropriate expectations for the children's age developmental stages, giving children too many responsibilities and too much autonomy for their age, sexualizing a child or the children, making negative comparisons involving the children, imposing inappropriate discipline, or not being able to distinguish between discipline, guiding, and punishment, which is hurting. Treatment strategies for child abusers. When parents lack good parenting skills, they will need help. Recognizing the importance of appropriate parenting behaviors. Seeking assistance in becoming better parents. Identifying others who can support them. Understanding how substance abuse affects responsible parenting. Remember to reinforce clients' positive skills and praise them when they demonstrate appropriate parenting behavior. Parents need help learning about child development, good parenting skills, the impact on child abuse on a person, how to form good relationships with a parent or other adults, healthy personal and social developmental skills. Counselors should make clear that they are concerned about the client both as a person with a substance abuse disorder and as a parent with responsibilities. The client's safety and the children's safety are both important. Legal issues. Record-keeping instances of abuse and neglect revealed by the client must be recorded. To protect the provider, the record should state that the client reported abuse, not that the client was abused. Counselors should record information in an organized, professional manner. Document only the factual, observable behavior of the client in his or her statements. Omit judgmental statements. Respect the rules of confidentiality. According to federal regulations, information may be provided to outside sources only if there is written consent from the client, a court order, or a qualified service organization agreement. Mandated reporting. All states require counselors to report incidences of known or suspected child abuse or neglect, such as when a child has been injured by a parent or other adult, other than accidentally. A parent or other adult does not seek medical attention or fails to follow medical advice for a seriously ill or injured child. An adult has inappropriately touched a child or made the child touch an adult inappropriately, sexually abused a child, or exploited a child. A child is not attending school and the parent refuses to send him or her to homeschool must be documented. Consult a supervisor before reporting suspected child abuse or neglect unless immediate action is required. The child is in imminent danger. Agencies should provide orientation about reporting policies and procedures to all staff. An adult supervisor of abuse usually discusses events that took place many years before, which generally are exempt from reporting requirements. However, if the person who abused or neglected the client has custody of other children, the program should seek advice about whether it has a reporting responsibility. Provide only the basic information required by the state law, the names of the reporting counselor and the treatment program. The importance of the counselor-client relationship must not override the counselor's duty to report abuse. If a client has a history of violence, the counselor must also consider his or her own safety. CPS agency investigations. After receiving a report, CPS staff assesses the situation and develop a service plan that details the conditions the client must meet to retain or regain custody of their children, a timetable for accomplishing each, the resource available to help the family. The goals of CPS agencies and the court system differ from those of the substance abuse treatment provider. They focus on the children's safety. When dealing with CPS agencies, courts, and law enforcement, counselors must ask their supervisor's guidance, consult with their client, and consult state law or a lawyer familiar with state law.